So welcome Professor Derek Bolton from King's College, talking about care pathways, and I'll leave you to sort of
the rest. Thank you very much.
The rest there.
Thank you, Andy. Now, let me say that I'm going to be talking more about care pathways as they apply in National Health Service CAMs as opposed to local authority or the voluntary sector. And that's the origin of care pathways, so it's natural enough, apart from the fact that I work in CAMs. But I have to say that the more interesting question, particularly for this room, is how care pathways might work across a geographical patch in a borough, which I gather is linked up with the joint commissioning of services where you try to make a coherent service across a borough or a county, which involve CAMs, NHS CAMs, local authority input and the voluntary sector. That would be a good idea, to have something like a care pathway or something like that across a patch. So that's interesting. It's not what I'm going to talk about, and there are people here in the room who know far more about that than I do. But I'm going to be talking about care pathways in an NHS CAMS and how it fits in with Child and Young Persons Act. Now, this is a slide of CYPI principles. Oh dear, gone one too far. That says systematic outcome evaluation, and that says user participation. And I don't know the origin of this slide, it isn't mine, but I hope it represents what CYPI is meant to do. But the particular thing I'm going to talk about is a curiously missing arrow, in a way, that is meant to link the evidence-based practice with the person who is receiving treatment. So that's the origin of what a care pathway is, getting the person with a certain condition to the right treatment in a timely way, and to review their progress in it, and hence that's linked with the CYPI principle of systematic evaluation and review. So I'm now going to go back to the start, having introduced it in that way. So this is a definition of a care pathway. That's an NHS type understanding of what a care pathway is. You can see that words like guidelines, protocol, evidence-based, patient-centered, is all CYPI initiative compliant. In fact, CYPI Act and the notion of care pathways come from the same policy and science context. So it should be no surprise here to be thinking about care pathways. Now, if one looks at the literature on care pathways, they soon get very, very complicated. They start off with things like coronary care and orthopedic services. You know, they don't come from psychiatry or mental health. They are very complicated. They can get very complicated. You see, they're detailed essential steps in the care of patients with a specific clinical problem, and they actually build in multidisciplinary into it. So these are like orthopedic care or coronary care, where it's multidisciplinary. Well, we're used to that. But they do get complicated, and the aim is to link evidence to practice and optimise clinical outcomes. That's from a Cochrane review. One of the things the reviews conclude is that care pathways are somewhat mixed in their outcomes, and they're rather difficult to evaluate because they're very complicated. This I don't intend you to read. That's how complicated it becomes. So this is an anxiety disorder care pathway we've got in SLAM, and it will take a while to explain it, let alone to understand it and to implement it. It gets complicated. But the core idea in it, this is from the Bandelier website. This is an interesting website in the University of Oxford Medical School or Department of Medicine. It's dedicated to analysing and updating results and giving advice on evidence-based practice. It's very good. So there's one part of that in this particular paper which says diagnosis is to make sure that you're treating the right patient, you got the condition right, I'm afraid once one starts on the care pathway route, diagnosis comes up. It's inevitable. It starts off with that. Treatment is getting the right patient, the right treatment, which got to do with it, evidence base in this thought space. Organisation is getting the right patient to the right treatment at the right time. Now that in NHS improvement quality speak is usually called clinical flow. You're meant to find obstacles in the pathway that are holding people up. So they might get to the right treatment eventually, but after too long. So there's also a time fashion in this. And the pathway is to do all of that, but also to treat people in the right way along the care pathway. Now that might include, in the case of orthopedic surgery, you don't only get them to surgery, but you avoid side effects along the way like bed sores and so on and the multidisciplinary. So it's trying to manage the whole process. Now, in summary, at least a part of the care pathway idea is to codify and facilitate young people, in this case with health conditions, to be assessed well and to assess the or an appropriate treatment as speedily as possible, and to have protocols for monitoring progress and review. You might want to change your plan. It's important not to keep people in a treatment or therapy that isn't helping, obviously, unless you're conscious of that and you're aware of it and any other options. So that's the slide that I showed before. So it belongs with that. Now what's happened here is in the care pathways is what the CYPI training initiative does. It was all started off to train the workforce, to improve the skills in the workforce for specific evidence-based treatments for specific conditions. This was CBT for anxiety and depression, and parent training for conduct problems, but below the age of 10. And then it's been increased, as you know, to IPT for adolescent for depression and systemic family practice for eating problems, conduct problems in adolescent depression and self-injury in adolescents. So, but all of these times there's a pairing of a treatment and a condition. And that is absolutely essential to the idea behind IAPT. And when I say it's only these that have any evidence base, you will not find any, he says, I mean you might find one, that has any kind of randomized control trial evidence, let alone a lot, or even a quasi-experimental design evidence, that's not trying to say what problems you are dealing with in diagnostic terms. And then say, now, but once the therapists have been trained, it does make a requirement on the service to get service users properly assessed as to whether those conditions are present or absent. It's like, does the young person have significantly lowered mood or not, or obsessive compulsive disorder or not? It does require the service to have in place the capacity to assess that, and after that, it requires the service to be organised in such a way that the person with the condition joins up with the therapist with the skills in a timely way. Now, services find that quite difficult to do in year 2. My own opinion, for what it's worth, is that complying with the CYPI evidence-based practice component minimally requires that the service is able to assess whether the person has a condition or not, and if they do, get them to someone trained in that therapy in a timely way. If they don't do that, I think the whole evidence-based training aspect has been lost. Pointless. Now, I say that they're expression and a vehicle of quality improvement. They're an expression because the assumption is behind all this that a person with a particular kind of problem that has a treatment that has an evidence base is more likely to recover from that with that treatment than some other treatment. I mean, that's an assumption, but it's behind all this. But once they start on the journey of the care pathway, then it requires that there is regular monitoring of progress, which is the ROMs and PROMs aspect of it, and also that there is ample room, especially when the journey is spelled out, to involve children, young people and families in how it can be improved. So I think it's it's IAP compliant. Now, there are principled objections to all this, and there are practical obstacles. The first principled objection, which one often hears, is a disapproval of diagnosis in the first place. Either because people don't approve of what the diagnosis is, because it's too medical, or too pathologizing, or because people are far too complicated to manage them just on the basis of a diagnosis. So these broadly are the two objections that one might hear. They're principled. That would count against the whole idea of evidence, but yes, I think you can't get evidence-based practice off the ground without that, and you certainly can't get the evidence-based part of CYPI service transformation off the ground without that. So it does deconstruct it. It undermines it. Or there can be a skepticism about evidence-based, and as you all know, there's a long conversation to be had about whether it's proper evidence and whether it applies in the real world and so on and so forth. So all those principled objections, and there might be more, but they're the two that occur to me. First, those principled objections will stop anyone wanting to set up a care pathway of this sort. The other ones are practical, that there aren't enough people around in the service who feel confident in making a diagnosis. And that's a problem in CAMS, if one looks at it from this point of view. The other thing that I've been very aware of over the years, and certainly as CYPI has developed, is that there is a trained therapist churn. So you can train up therapists either inside out or outside of it, and then they go somewhere else, and that's fine, except your service isn't fine from this point of view. The other thing, which I think is absolutely major, and this is interesting because it links with the commissioning issues, is that teams are organised around age and patches, and they always have been. So we have an under-8 team and an under-teenage team and a teenage team, and looked after teams and yacht teams, and so they're all organised around age, or not condition so much as status that's interesting, and geographical patches. And then it's very difficult. This, I think, is the same problem as the NHS has in relation to where to put its accident and emergency centres. What they would like, what leaders in the NHS and any doctors would like to do is have a few specialist centres a long way from home. But what the community wants is a nice centre next door. And those two things are a poor fit, as the poor NHS is struggling with at the moment, and it's the same problem for us. If we all organise our teams around patches, we're going to have trouble providing the specialisms on each patch. This is a major problem, it seems to me. So, thank you very much.